to avoid tourism. And like, why are you having this here?
Okay, it's live.
Okay.
You're doing it? Okay. Just wanted to make sure somebody was on. Okay.
STS channel, right?
You are late.
Either it's an honor and a privilege, or it's a punishment.
Hey guys, I just want to remind everyone to turn their phones down, off, whatever. If anyone's back that way, if I'm gonna leave the door open for now, but if there becomes like an instance of disturbance, like I think we had last time, would you just kindly give it a close? It's best to leave it open while if we can. Anybody got any questions or anything? And Oliver, we're already live.
Yeah, awesome. Excellent. Good afternoon, folks. So I'm going to call us to attention. I'm really excited to introduce Dr. Tom Ewing today as part of our STS at VT seminar series this semester. Tom is a professor in the Department of History at Virginia Tech and the Associate Dean for Graduate Studies and Research in the College of Liberal Arts and Human Sciences. He received his graduate degrees in history from the University of Michigan with a focus in modern Russian history as part of his PhD dissertation. Prior to his appointment at Virginia Tech, he served as an assistant professor of history at DePauw University in Greencastle, Indiana. His monographs investigate 20th century Soviet education policy and practices. Recently, Tom has invested in the digital humanities and currently utilizes these technologies to explore the history of public understandings of medicine. Alongside classes in history of globalization and imperial power, he teaches the Data in a Social Context course as part of the Data and Decisions minor at Virginia Tech. His presentation today is entitled A Frightful Increase of Mortality, Statistics and Action During the 1889 to 1892 Flu Epidemic in New York City. And this examines the reporting of death statistics in the midst of the quote-unquote Russian flu. So without further ado, please welcome Dr. Tom Ewing to the stage.
Thank you. There's a genealogy to that introduction. There's a part in there about where I used to taught that I didn't know was out in public, but I guess it still is. I mean, it's fine, but it's just weird. Yes, I did teach there once upon a time. Thank you very much for having me. I'm really delighted to be here, and I should thank both Professor Schmidt and Professor Vinsel for accepting my invitation to invite myself to come and talk with this group. And I appreciate Joe and all of his team in coordinating this. I did present to this group about 10 years ago, and I think at that time it was like 5 of us sitting around a table in Lane Hall, so it's become much more complicated over the years. But this is a department, the faculty and the graduate students, and this particular seminar series that I've always really admired. You know, I think it's incredibly important to build a scholarly community and to sustain it and to be committed to these meetings and attending and presenting, and I really appreciate the opportunity to come and talk. So this presentation is excellent. It looks great on my screen, but nobody else can see it?
We'll switch.
Okay. I mean, I love this presentation, but I really want other people to see it. So this would be a good time to do that. Yeah? Okay. Maybe bigger? There we go. All right. Thank you.
It won't always be like that, Tom, just so you know. I will move through it as you move through it, but it will not always be full screen.
Okay.
It will be switched in and out.
All right. There's a lot of text and a lot of numbers,
Okay.
so it'd be good if
I will-
full screen would be better. Less of me, more of this. Okay. All right. So yeah. So as the introduction suggested, the topic for today is the 1889 and 1893 influenza epidemic in New York City, sometimes called the Russian flu epidemic. I'm not actually going to talk about that today, but I certainly can. And I'm going to come back and talk about the cartoon and the quote later on in the presentation. Yeah, it needs to be bigger. Thank you. The title, A Frightful Increase of Mortality, comes from a newspaper article in the New York Herald on January 5th, 1890. You can see the headline, Grips ravages worse than cholera, alarming increase of mortality from the epidemic, as shown by the record for the week. And then this particular sentence, the quote that I pulled out, a frightful increase of mortality from pneumonia, bronchitis, phthisis, and heart disease. That's an old term for tuberculosis, in case you're wondering, as well as from influenza. And then in this article, they reprinted this table of statistics from the New York Department of Health that was kind of confirming these numbers. You can see what they're doing is they're setting up the data from the week ending January 4th, comparing it to the previous week, as well as the average over the past 5 years. And these are, very common methods in epidemiology and also in other kinds of statistical analysis. You don't just present the current number, but you provide some sense of comparison. In this case, the previous week, which was really the first week when the epidemic reached New York, as well as the 5 years before the epidemic. But then there's also this paragraph here that provides a little bit of interpretation. Average number for the week corresponding to last year in the series of years is 790, and you can see how much higher it is, 1,202, compared both to the average and before. Then a little bit of more colorful language. The influenza has made a clean sweep on its own account alone of about 370 people. This is amplified in the rest of the article, connecting the influenza to insidious pneumonia with even more colorful language, like a serpent in the dense African jungle fastens its fatal fangs on the victim before it is seen or even suspected. And then there's this really interesting quotation from one of the members of the Board of Health, not named for some reason, admitted that the disease was dangerous and that the board could do nothing to prevent its spread. We feel, said he, that the influenza has appeared here in its most aggravated forms and that the largely increased death rate is probably due to the epidemic influence. We can only, as we said before, advise people to clothe themselves warmly and seek the advice of a physician immediately they fall sick. So basically, they're throwing up their hands saying, we can't do anything, dress warmly, see a doctor, there's nothing else we can do. And I'll come back to why that's such a striking statement from a health official. So what I want to do just briefly here is back up a little bit and explain how I got to this point in my research and this particular presentation. I appreciate that there's some graduate students here. And one of the things I'm very aware of when I talk to particularly doctoral students is as you pick a topic for your dissertation, be aware that this topic may be with you for a long time. In this case, I've been working on this for about 10 years, which is not something I in any way anticipated when I began in 2012 or 2013. But I've gone through a couple of phases. The first is, really thinking about the Russian flu in terms of information networks. And originally, I was asking a question about the relationship between how the influenza was described in medical journals, what you might call an expert discourse, and in newspapers, so a more popular discourse, and what was written for the public, and as you could see in that example just now from the New York Herald, often very colorful, vivid language. And I also, in the early stages, got interested in kind of text analysis, computational methods for examining texts, and so that really shaped some of the initial publications for this project. 2 articles that appeared in medical history, both of them looking at ways, the relationship between what was being published in in medical journals by physicians and primarily for physicians, but then how those that analysis and those recommendations then were sort of percolated through the popular media, in this case in newspapers. And then most recently there was a chapter where I looked at how a newspaper correspondent, or newspaper in Washington, the Evening Star, reported on the disease as it came to the city at about the same time period, very late 1889 and early 1890. So that was kind of the question I had in the first stage. I then switched and really started looking at data. And as Oliver mentioned, this is when I began teaching something called Introduction to Data and Social Context, which I know some of you know well, and really started to ask about data in a more critical way. Okay, where do these numbers come from? What do the numbers mean? What's in the numbers? What's hidden by the numbers? Where are populations omitted or excluded or misrepresented? And so I spent a lot of time during those couple of years looking at I'm calling vital statistics, basically publications of health departments reporting on particularly influenza, but other diseases as well. And part of the reason I wanted to do that is I was looking for an approach that could connect with a different set of scholarly audiences, particularly those interested in influenza and respiratory viruses, also public health, and to some extent epidemiologists. And so I started looking at a different set of source materials and frankly writing a very different kind of article with the goal of reaching these other audiences. So the first article was published in, I guess, 2019 in a journal called Influenza and Other Respiratory Viruses. And this was looking at case studies from Indiana, which I picked because the Indiana Board of Health had this really detailed set of statistical reports from this period, as well as reports from county health departments and newspapers. So I had a really good set of data. One thing I learned is that I'd written an entire manuscript the way I would write a history manuscript, and then I actually went and looked at the guidelines for authors for that particular journal. I had to completely rewrite it, because they wanted a very different structure. The next time I did it slightly differently. I also got this article accepted and thought, this is great, this is going to be easy. And the next 4 articles all got turned down, but one of them I resubmitted someplace else, and that was published by Public Health Reports, I guess in early 2021, that did a kind of similar approach in looking at statistics in Connecticut. And so this was the shift I made leading up to the pandemic. Things changed in the pandemic. I became interested in the history of that, kind of lessons we could learn from history. I'd also done some research and some teaching on the 1918 flu, and actually shifted most of my attention to doing that. And some of this was done with 2 colleagues, Ariel Ludwig, who was a PhD student here, who finished in the spring of 2020. So I occasionally refer to her as a graduate assistant. That's a misrepresentation. She was a doctor by then. But she worked with me, and also Jessica Brabel, who was a graduate student in the History MA program, starting in the summer of 2020 and then continuing through that next year. And we got really interested in masks and the way masks were used during the 1918 flu. The first article I wrote was published in May 1st of 2020, so relatively early in what was then called the Health Affairs blog. It's now called Health Affairs Forefront. I have often thought about the title, which at the time I thought was one of the best titles I've ever picked. That could easily be retitled as Flu Masks Failed in 1918, and they will fail us again. But it was a different argument I was making then. But then with Jessica and Ariel, we did a lot of case studies, including 2 that were published in Nursing Clio, one about perceptions of masked women, and then the other one that looked at a particular public health official in California, great name, Minerva Goodman, and how she got involved in this debate over masks. And so that was kind of a diversion. But I was really interested in this question of how history of epidemics could be used to inform our response to COVID. And so there were a couple of essays I wrote that really looked at these numbers, okay? And so I went back and looked at the numbers from 1918, 1919. And then I also published this other essay in the Washington Post in February of 2020, February 28th, 2020, the first American cases of coronavirus shouldn't spark a panic. Not the title I selected, definitely a title I regret. 3 years later, I think we can say the first American cases of coronavirus should spark a panic. But this was, I went back and looked in the very early stages of the Russian flu in New York in December of 1889, to look at the first case, or what was called the first case, which broke out in a family, the family of the father Klamroth, who were immigrants from Germany. And the way that it kind of created a media frenzy. All the newspapers reported on this one family. The main doctor in New York went and inspected them, treated them, tried to diagnose them. And so I was interested, going back to what I was saying earlier about this kind of networks of information. How do we focus on certain cases, certain victims, possibly to the exclusion of larger questions? So I still think the history is good in this article. I just regret the title. And then most recently, after COVID, if we ever get to that point, I've really changed the questions I'm asking. I've become more interested in anxieties and attitudes during public health emergencies, kind of an emotional sense of this history. I'm still interested in information networks, but now more interested in misinformation networks, again, coming out of COVID, and thinking about quantification. What does it mean when we are in fact surrounded by numbers about a disease, about an outbreak? And so I've also as part of this project all the way through, but more recently, been working with undergraduates. And so these are 2 essays that were published, one a year ago in about statistical analysis in Paris, about the early stages, and then more recently one in Mexico City. And the advantage here is the undergraduate research assistants I've been working with read languages that I don't read. So French in one case, Spanish in another. And so it's been a way to really broaden what I'm interested in doing and trying to do. But then I've also gone back and looked at, as I said before, some examples of misinformation during this earlier pandemic. One around the treatment of quinine, another more recently in the fall, about whether or not influenza can be spread by touching money, currency, and then also a discussion about the origins of the Russian flu in relation to an endless debate, a recurring debate about the origins of COVID-19 in Wuhan. Okay, so that's some background on this and why it's taken me 10 years to get to this point. So there's 3 parts I'm going to talk about today. Part one is about vital statistics from these 4 years. And this is in some sense an empirical question. What happened? How do we, what do we measure? What do the measurements say? The second is a little bit more theoretical, and the subtitle of this talk, Statistics in Action. What does it mean, the way that these numbers were counted and reproduced? And then I'm going to finish by talking about a particular, what I would call an agent in a network, an information network named Dr. Louise Fisk-Bryson. But there's some themes that connect not only all of the parts of this presentation, but also the earlier research I've done. How does it change the way we study a pandemic after living through or in a pandemic? Thinking about quantification in daily life and the way people think about numbers, and then also networks of information and infection. So, why New York City? We're starting with New York City, or I'm looking at New York City because it has some of the most detailed statistical information from this period. It was by far the largest city in the United States in 1890, about 1.5 million. And at the time, Brooklyn was counted separately. That would change later on in the 1890s. But if you count New York and Brooklyn together, it's more than 2 million. The next 2 largest cities, Chicago and Philadelphia, were about 1 million, and then it went way down to St. Louis, Boston, Baltimore, and others. So by far the largest city. Because there are a lot of people, there are a lot of deaths. 40,000 deaths, depending on whether you count stillbirths or not, and a death rate. And so one argument for looking at New York City is to say, well, this is where, had the largest collection of people. But it also had extremely detailed information during this pandemic, and so it made sense to really look closely. So this is one measure that tells you how much things changed when this epidemic hits. In 1889, there were 7 deaths attributed to influenza in New York City. 1890, 320, 1891, 773, and you can see. So, if you look at this 4-year period, 1890 when the deaths really begin through 1893, you can see how much things have changed in the attribution of deaths to this particular cause. And so by this measure, something substantial has happened. But one of the things I'm interested in is how did the Board of Health count deaths? How did they measure them? How did they record them? How did they present them? And so it's actually in the 1894 report, towards the end of this pandemic, that they provide this really interesting table, which is the number of influenza deaths by week over 5 years. And so if you have lots of hours, as I did, you can convert that table into a spreadsheet, and then you can convert that spreadsheet into a nice chart that I think really vividly shows what happens during this 5-year period. It's a little deceptive because the week ending January 4th is right when the pandemic starts, and so that number might be a little bit higher. But you can see that very significant increase in the spring of 1891, and then another one at the end of 1892 running through early 1893, and then 2 more spikes in the spring of 1893 and again at the end of 1893, 1894. So when does the pandemic end? It's a little hard to tell. You can measure it in different ways. It's very clear where it starts. It's very clear where the highest number of deaths happen. So this is both, statistics, but it's also a narrative. It's a story. It's a story about how a disease that was not perceived as deadly at all, only 7 deaths in the entire year of 1889, suddenly becomes more deadly, but also has these changes over time, in these moments when it becomes really acute, and others where it's not so serious. One of the challenges with studying influenza epidemics is Most deaths are not attributed specifically to influenza. They're attributed to associated disease. This is still the case if you look at the Centers for Disease Control and Prevention. They combine influenza and pneumonia deaths together in most cases, talk about PNI, pneumonia and influenza deaths, because often influenza is a contributing factor, and so you have to look at these other deaths. And you can see this chart of pneumonia deaths by year, how much they also increase, excuse me, in 1890, in 1891. And if you take that same technique that we saw in the New York Herald of combining years with high rates to averages, so this would be the average from 1883 to 1889 is the red line, you can see how each of these years is significantly above that average. And so this is something to, just to provide a means of comparison. I have to pause here for a moment. I use the word significantly in the common English definition, meaning major, important, a lot. I submitted a piece to a statistics journal, and every place where we use the word significant, they crossed it out and asked for another word, because significant means something very different in that world. So when I use it in my common way, I sometimes forget. This is another way to think about this. This is deaths from all causes. And so the black line shows, again, the average over 4 years, in this case, 1886 to 1889. And you can see the blue, the pink, and the green showing, again, where these spikes were with the influenza epidemic also contributed to an increase of deaths from all causes, both in comparison to the averages, but also in comparison to these other stages in the pandemic. So these are all ways to, in some sense, answer the question, what happened during this epidemic? When did it happen? How many deaths? How do we disaggregate deaths specifically for influenza from deaths from associated disease, from increases in all of the deaths? None of this really answers the question, how many people died from this epidemic, because again, pneumonia had a lot of deaths prior to the epidemic. And so then the question begins, okay, how do we think about excess deaths, right? How many deaths can we say are specifically because of a particular epidemic rather than just the regular number? And here, this kind of answers that question. It looks at the average, again, in this case, over a decade from 1880 to 1889. It looks at the total over these 4 years, 1890 to 1893, and says, okay, if we take out the average, how many are left with excess? And so you can come up with a number around 12 or 13,000. It's not a great number. It doesn't count, for example, deaths from diseases other than pneumonia and bronchitis, tuberculosis, for example, or heart disease or other kinds of things. But if you look at all excess deaths, you can't really attribute them all to necessarily influenza, because as we saw, that happens only in certain cycles and so on. But it's a partial answer to that question. Okay. All of this brings me then to the second part, statistics in action. And here I was trying to figure out, how are these decisions made about what to count and what to report and how to report them? And in this case, we know who the people are. We know who the members of the Board of Health are, the secretary, and particularly the Bureau of Records, Roger Tracy, John Nagel, and others. But I have not been able to find any kind of archival records related to the Board of Health or Bureau of Records. I was in New York quite a few years ago, went to the Municipal Archive, didn't find anything except the published reports from this period. There are things later, around the 1918 flu, that other people have looked at, but I couldn't find any kind of interior deliberation or any kind of discussion. It's easy to look at the newspapers, and this is something I've used particularly in the early stage of the project, and say, if you look at 1888, so these are two New York newspapers, the Evening World and the New York Times, the keywords influenza and grip, which was at this time pretty much a synonym for the disease, hardly ever appeared. They start to appear in 1889, but most of that is November and especially December when there's reporting. And then you have this, flow of information, 1890, 1891, 1892, and then it gradually dissipates after that. So it's, again, looking at this record, you can say, all of a sudden, the newspapers were reporting about this disease pretty clearly. But it's much harder to find records about the Bureau of Health or about particularly vital statistics. Keyword searches for vital statistics can bring up a lot of records, but there are a lot of things that are irrelevant to this epidemic. They get called in for court cases and inquests and reports on other kind of diseases and so on and so forth. And so I didn't really want to answer the question, how did the Registrar of Vital Statistics and others respond, when this disease began. I've done that in other contexts. I have some evidence of that. You saw that from their very first example and that quotation. But it didn't really answer the question, the larger question of how did they make sense of this epidemic over time, and what did the numbers mean as they were recording them, as they were interpreting them, as they were presenting them. So that brought me to this book, which for some reason I like the diagram on the right, which I think is just standard Amazon for showing you how big something is before you buy it, but somehow, I don't know, I just liked it. And I think unlike some of my distinguished colleagues in the room or on television, I did not read this book in graduate school. I read this book last month. Actually, I read it over several months. My graduate school French theorists were a lot of Michel Foucault and a little bit of Derrida and Lacan and Bourdieu, and that seemed like plenty. I didn't need to go find more. And it's only when I got into studying the history of medicine and then, thinking about kind of the construction of facts in terms of vital statistics that it kind of brought me back to this figure and his influence and so on. So I did finally read the book. And I'm not quite sure how to use it. And I think part of the reason that I wanted to do this presentation was actually to ask for your help. I reformulated this statement from early in the book, scientist who faces one that knows, the other that does not know yet, in the diagram, to ask whether you could say the same thing about statistics, one that knows, the other that does not know yet. Because in some ways, what I'm trying to figure out with the New York Health Department and its statistics is, what did they know, but what were they learning as they went? What were they making up? What were they constructing? Because the way that they discussed this disease and the way that they counted it and the way that they presented the evidence changes. I was going to say changes significantly, but I can't. So I'm going to say changes dramatically over these several years. And so what I'm trying to figure out is, how was this a process of them not just recording the disease, but also in some sense inventing it, creating it, reporting, telling the story. So this is kind of where I am in thinking about this. And I'm happy when we come to the questions to bring this slide back up, and you can tell me where it's simplistic or misleading or not very helpful. They were incredibly confident about their numbers. They really believed that they were documenting what really happened. They said that their death records were 100% accurate. It was not possible for someone to die in New York City and them not to know about it. They conceded people could get married and they didn't know about it, or they gave birth and didn't know about it, but they were very sure they counted every single death. And they were also very confident that the more accurate they were in their statistics, the more they were contributing to improving public health. That there was a close relationship between recording and policy, how this would improve public health. But in fact, you can see in looking at these documents that they weren't actually constructing facts. They were making this up. They were creating this representation collectively, engaging with each other, but also over time and in response to changing context. And the obvious example is, before 1889, influenza was not perceived as a deadly disease. They just didn't count it. Or it had very, very low priority. This obviously changes suddenly. Now there's a separate section in the health reports that looks at influenza and counts it in various ways. They were very aware of these connections with other related diseases, and they did count that. Wasn't meant for me. But they weren't very consistent about this, and they were often incomplete. They adjusted their timelines. Usually they were reporting annually, in some cases monthly. But with influenza, they started reporting weekly, or in some cases even daily. Here's the number of people dying on each of these days, because they really wanted to track this dramatic pace of change. And so they were telling a story through all of these tables and spreadsheets and texts, which adjusted to conditions. It moderated and was modified over time. But they were always very sure they were accurate and truthful. They didn't go back and revise, as far as I know, what they were doing. And so let me give you some examples of this. There's a lot of text here, which we're obviously not going to read. But this begins in 1890. with the annual report. And again, the annual reports don't come out until the spring of the following year, so there's a pretty good time lag there. They talk about alarming proportions of the disease, reach its height, slowly abates, down to very specific days of the week, when this disease was there, and then obviously comparisons, in this case going back almost 20 years to 1872. In July, which is usually when the most deaths happen, and saying this was, that had been the deadliest week, and now we've got another one. This was a table that appeared, I think, in the 1890 annual report, showing the daily number of deaths. And you can see how these were being counted. In this case, they went back into 1889, because that's really when the deaths started to go up. And then they counted all the way through early February. And you can see, they're really trying, it's a very granular level of information about this disease. That's what they thought was most important in reporting on this as an annual. And again, I can make comparisons to the previous period of time. If you look at January 1889, it was about 110 deaths per day. Almost every day in this entire period from the end of 1890 through early 1890 is above average in most cases. We'll come back and talk about this. They actually went through and writing the 1890 annual report and looked at 5,500 death certificates to see what the exact cause of death was. And in particular, how many were attributed to influenza's sole cause of death, which was a very, very small number of 18. How many had influenza ending in another disease, pneumonia bronchitis, many, many more deaths only from pneumonia bronchitis, yet not connected to the epidemic, even though it was exactly the same time period. And then this other category of disease X complicated by influenza, and you can see how many died in there. And so, they're really trying to figure this out. How do we explain the number of deaths that can be attributed to the epidemic, and trying to, kind of document that in these cases. They went through and looked again, as I said before, at the number in this period of time, the average over previous years, and then how many excess deaths can we talk about, in this case, just in January, more than 1,000. The 1891 report talks about this more deadly and this greater spike in the spring of 1899, which was kind of an unusual time for influenza. And again, they give this narrative, where they're saying probably due because the deaths directly attributed to influenza were not sufficiently numerous to count alone for this increase, was quite generally distributed over the whole list of diseases. And so they're kind of giving you an interpretation of what happened that goes on in great length and great detail about all of these different causes and the time periods and so on. Again, coming back to this question of how many excess deaths can we reliably attribute to this epidemic and its related diseases. In 1892, they had this, I would say, almost poetic explanation of the 3 stages of this epidemic in early 1890, in the spring of 1891, and then again in 1892. The first being the fiercest and most sudden and unexpected, the second the most fatal, and the third the most prolonged. So they're giving you really 3 almost qualitative descriptions of basically numerical measures. In 1893, again, they were trying to compare averages in the same time period to these increases. And then as I began with 1894, they have this really interesting chart of weekly deaths over an entire 5-year period. So what you see in the public health reports is really this attempt to construct a narrative around numbers, using numbers, but in very much as a way of saying this is what we think what happened, and we're giving you this interpretation. Okay, last part 3, agency. So I started with this quote, the history of the present epidemic is the history of all past epidemics, which as a historian, I can appreciate, and certainly one of the things I was very aware of in the spring of 2020, was thinking about how do we think about COVID in relation to past epidemics, and what lessons can we learn and so on. So that quote comes from a talk given on January 21st, 1890 at the New York Academy of Medicine by a doctor named Louise Fisk Bryson. It was published in the February 1st edition of the New York Medical Journal, and then was subsequently republished in another journal from the Academy of Medicine. Louise Fisk Bryson, born 1852, died 1941. Her father was a very prominent minister, an author, and science dilettante. went around doing experiments and demonstrations. Her mother was a daughter of a judge, so some very prominent family. Her husband was also a writer, Gilbert Bryson. They were married in 1874, and then here's where it gets interesting. Actually got divorced in 1886, and they were divorced in Kansas. And so this has become a source of tremendous frustration for me, because I expect to find educated, upper middle class Northeasterners. I expect to find lots of information about them from this time period, using genealogical records and newspapers and so on. And I can't find anything else for her. Her obituary is one line in the Baltimore Sun in 1941. Sorry, I'll come back to this. I can't find, she's in the 1920, 1930, and 1940 censuses. This is her listing from the 1920 census. Louisa F. Bryson, age 67, so the age matches up. Physician, attended a medical school. At this time, she's living in Maryland. The record for 1930 and 1940 is very similar. But I can't find anything else from her. She appears in the New York phone book. I can't find a listing for any of the other censuses, 1870, 1880, 1900, 1910, for which we have detailed records. There's no mention of the actual wedding, even though her husband was also from a prominent family. Can't find her daughter, Lorraine Marguerite Bryson, who was born in 1875, got married in January of 1898 and died in that same year. She gave birth in October 1988 and died just a few days later. So this is her tomb on the right from the wonderful website Find a Grave. If you haven't seen it, you really must. And on that website, and this is her marriage announcement, and it mentions her, the daughter of the famous Dr. Louise Fisk Bryson. Somebody posted a picture, that picture, which they've luckily posted in a version that large that doesn't get any larger. So maybe one of those people, maybe that's her wedding picture, maybe one of those people is Dr. Bryson. I can't find any other photograph of her. She does have a Google Scholar site profile, because she was a very prolific author. Some of these are translations. She tended to write a lot of summaries of articles that appeared elsewhere, often in French, or reports on things. But she actually published quite extensively on traumatic hysteria, other kinds of emotional diseases. She wrote about women's health. She wrote about clothing, dress, appearance, and how it related to health. And so there are lots of mentions of her in newspapers from this time period. As you can see in journals, she even has an entry in the Virginia Tech University Library's database. So she's very visible in some ways, but all of the things I would expect to find about, like I said, an upper class, well-educated, prominent New Yorker just aren't there, and I'm not quite sure why. It's always hard to find names, particularly for women who began as Fisk and became Fisk Bryson. Sometimes it's hyphenated, sometimes not. So there are various reasons, but I've spent a whole lot of time trying to figure that out. But what we can do with the statistics is situate her talk in a chronology, right? So she gave this talk on January 21st, 1890. And so what she had leading up to that were more than 3 weeks, 21 days of higher than average deaths in the city where she was living and working, right? So she must have been aware of the immediate impact or scope of this epidemic. Like I said, this was reprinted in this journal called Postgraduate from the New York Postgraduate Medical School, New York Academy of Medicine. I happen to take all of the pages because this is a better reproduction than the one I had earlier from the New York Medical Journal. So how does she explain this epidemic, right? So this is her talk, then printed, the transcript printed in this journal. And there's also a discussion that follows afterwards. She starts with the history. Ever since the year 1510, talks about these epidemics and how they have been spread around the world and how they have been documented, and presumably much of this came from medical textbooks or medical journals. She talks about how the disease is transmitted. It's infectious, it's not assured. There is good evidence for it to be contagious. At this point, there are still some physicians who are talking about miasma, that the disease is somehow in the atmosphere or it's in the ground. But pretty much the scientific consensus is that it's infectious between people, and it's particularly a microbe although they're desperate to find which microbe. She speculates, that maybe the disease, was concentrated around the Russian embassy. Somehow the Russians brought it over to Paris, or it came in dispatches in the mail. She talks about treatment. Has always been essentially the same, various ways to both treat the symptoms, but then also help people to recover. She goes through a very bizarre kind of speculation that maybe the influenza is caused by electricity in the air. And again, 1890, people are just trying to figure out what electricity is and whether it's safe or whether it's dangerous. Maybe it's earthquakes that have affected the humidity around the world, and maybe that's what's causing this epidemic to spread. You can tell she's a little bit tentative about this, but nonetheless, she presents these. This struck me, having lived through an epidemic. Epidemic influenza exercises a powerful alterative effect upon the whole organism. Under their malign sway, the cheerful have become irritable, the irritable melancholy, and the melancholy given over to nameless sorrow and leaden-eyed despairs. I've definitely become irritable. I don't know if I can attribute it to the epidemic, but it's there. As I said earlier, talking about the kind of psychological, emotional effects of living through an epidemic. She really wants people to record the epidemic as it's happening. She encourages doctors to keep a record so that they have this for future, sort of observatory of epidemics. And then I wanted to end with, this is not the last part of our article, but this is the last piece I want to talk about, because she wants to talk about who's affected by this. The disease seems to prefer the rich to the poor. I think that's actually misleading. A lot of the early victims were prominent, the royalty in Europe and then businessmen and others in the United States. I think that was deceptive. They just didn't realize how much it was affecting other people. Those who are outside seem to be more liable to attacks, which is kind of backwards from what we experienced in COVID. Certainly the weak and the aged are more vulnerable. First, women are attacked, then men, and lastly, children. This is something I'm still trying to figure out, whether there were more cases among women than men. Haven't seen evidence for that. And then the mortality is about 2%. In view, however, of the immense numbers attacked, this small percentage is sufficiently appalling in point of actual death rate. And that's, I think, a really important point. The disease in and of itself is not that dangerous. Most people recover, but because so many people get sick, there's actually a very large number of deaths associated with this epidemic. And you can see, when you look at case fatality rate, the deaths among the population sick with disease, seasonal influenza right now is very, very, very low. Very few people die of influenza in the United States. If you combine pneumonia and influenza, it goes up, but it's still less than 1%. The 1918 Spanish flu is estimated at 2.5%, which is very, very high for influenza, and explains why there were so many deaths. The best evidence I've seen for COVID, although it's really, really hard to measure, is more like 1%. So when she talks about this disease, the mortality at about 2%, that's a pretty dire forecast that she's predicting. It's probably not that high, but it's really hard to measure because nobody was keeping track of how many people were sick at this time. So, an agent in a scientific network. She is someone you can tell who's putting in, there's a lot of inputs of information, right? She's drawing histories of past epidemics. She's looking at the medical research. She's looking at patients. It's not clear which are her patients, which she describes some patients who she, drawing on other physicians. She has these case studies, and then she's also from somewhere getting these reports about the number of cases and the deaths. So probably from the newspapers, but then also from the vital statistics and also. But you can also see how she's speculating the causes of earthquakes and electricity. She's got colorful language in there. She's clearly embellishing, for her audience. And she makes some kind of common sense recommendations. I didn't put it in here, but she says, don't drink alcohol, it's bad for you. And so then those are the inputs that are coming into her, but then she's also disseminating this information in a lecture to the medical society in America's largest city, also the publication in this medical journal, and then it gets picked up by some newspapers who report on it. And so she also is fact-making, right? She is contributing to the sense of the epidemic as a factual, measurable event. But she's doing it, with her own perspective, with her own insights, with her own sources of information. What's interesting, both in her comments and in the discussion that follows, so there are maybe six or seven physicians who comment, none of them referred to her gender. Never came up. in the course of that discussion. It does come up in the New York Times. So the next day, January 22nd, the New York Times publishes this article under the headline Obesity and La Grippe, because there were two presenters. There was a physician who talked about obesity, and the newspaper actually commented on his weight and his size. And then the last part of the article was about Dr. Louise Fisk-Bryson, which immediately brought attention to her gender. It is not often that the speaker stand of the Academy is occupied by a woman, but it was Dr. Louise Fisk-Bryson, a brisk little lady in a coppered colored cloth costume, who read a long and carefully considered paper on La Grippe. And then the rest of the article summarizes that, including the part about the mortality and so on. And so, you know, this is the only place, and this parts of this article were published in other newspapers, that really calls attention to her gender as a very unusual woman physician and researcher and publicly engaged scholar in this context. So I'm desperately trying to find more information about her, although I'm not quite sure where else to go. Just in terms of where do these 3 years fit in the longer history for New York City? These are death rates from 1881 all the way up to 1900, so the epidemic is squarely in the middle. And you can see those 4 years that are in blue were clearly above what was a decreasing downward trend in death rates for the city over this period of time. It does continue to go down, but those years really stand out. And then if you look over excuse me, a longer period of time, again, the death rate does go down 1860s, 1870s, 1880s, 1890s, early 1900s, even with that epidemic in the blue. The one outstanding period here, of course, is 1918, and the Spanish flu, when the death rate jumps quite significantly in New York City before resuming its downward. So the Russian flu is not nearly as devastating as the Spanish flu in this context. All right. Let me finish by talking about this cartoon that I had up at the beginning. When will it loosen its hold? And you can see that the pincers have the word grip on them, G-R-I-P, which is referring to grip, G-R-I-P-P-E, which was, as I said earlier, very much a synonym for influenza. At this point, April of 1891, so almost a year and a half after that first report in January of 1890. The question is, when will this epidemic be over? And the visual on this is clear, I think, pretty sure, is meant to evoke Jonathan Swift, Gulliver's Travels, and the way the giant is being pinned down by the Lilliputians. There's a lot of images of that. This is actually a political cartoon from a few years later. So clearly this was, part of the discourse at the time. And I think the idea is that this, that we're all being confined by this giant, who has these pincers. When will it loosen its hold? I was struck in reading this because in the spring of 2020, I was teaching a course on the 1918 flu. And after spring break, when the students reassembled in an online format, I asked, how does this experience of COVID change the way you think about what we're studying in the 1918 flu? And this was one of their questions. When will we know that the epidemic is over? When did people in 1918 know that it was over? When are we going to know? And I think a lot about that question because I'm still wondering. And so if you situate this cartoon in April of 1891, you can see they're just beginning this second wave. And this was, again, a much more fatal wave. And more specifically, when this cartoon comes out on April 13th, they're not at the worst of it yet. They still have another 10 days of pretty bad death rates before it finally starts to decrease. That's not me. I don't know who that is. That's not my computer. It's not me. So I was interested in this cartoon as a kind of visual representation, not only of the impact of this disease, but also how people thought about it, how they made sense of it. And the timing on that beep was excellent because that is the end of my presentation. Thank you.
All right, so we're going to move into the Q&A portion now. So if you are on Zoom, you are welcome to put your question in the chat, or you're welcome to raise your hand if you would like to ask your question out loud. I'm also happy to read anything. And then for folks in the room, I'm going to ask you if you have a question to step up to the mic. If you think you might have a follow-up question, please stay at the mic so we can hear you. But if you think that you're good, you can go ahead and sit back down. So without further ado, anybody in the room want to kick us off? Andrew, go for it.
Hi, my name's Andrew. I'm a first-year master's student in the STS department. And my question is if there was any data regarding like long-term complications from influenza, like we see with long COVID today. There's been a lot of issues with keeping data on that, what constitutes long COVID, and I know influenza is a different virus and long-term complications are less likely than COVID. I think they're still possible.
Mm-hmm.
Was there any data or any discussions of long influenza or something similar?
Not long influenza, but they were very aware of, and New York was a good example of this, of kind of secondary effects. And so they asked, particularly tuberculosis, whether there was an increase in deaths from tuberculosis because people who had tuberculosis, their conditions were worsened by having influenza or pneumonia or something else, but also heart disease. And so this is one of the questions, when you look at all of the excess deaths, how many of them can you attribute back to this virus as opposed to maybe other things that were increasing those numbers? There was some discussion of people getting multiple cases, being vulnerable. But there was, and this goes back to the kind of early stages, a lot of the physicians, both in Europe, as it started to spread, and then in the United States, kept saying this is not a serious threat. People, you're going to recover. This is a short-term thing. Exactly the same thing they said in 1918. And then when that wasn't true, then they kind of came around and said, yeah, some people really have trouble recovering, or it takes them a long time. There's some speculation that maybe, some of these cases, well, there was speculation in the newspapers about suicides, that people were gone crazy with influenza and therefore were, throwing themselves out of windows or something like that. I'm very cautious about that. But they were trying to pay attention to it, and so there was a shift among the experts of going from saying this is not serious, don't have to worry about it, most people will recover, to yeah, there are not only there are certain populations what we would call with compromised or who are vulnerable, but others can take some time to recover.
We have a question on Zoom real quick from Ashley Shu. She just wants to know if she could see your slide with the Janus head again. Her, or I don't know how you pronounce that, so
That's
sorry
close.
if that's
Yeah.
incorrect. Her power was going in and out, so she was like, I missed something good, which is fair.
So there's two ways we can do this. I can go back to that slide, or I can hold up the visual aid. I don't know what you prefer. Was there a question associated with that or just a request?
It was a request, and just so she could see the slide, to get a little bit more context for that part of the presentation. So,
Done.
absolutely. So Christine, if you would like to continue us off, hopefully maybe Ashley will have a question
Yeah.
after.
I'll kill some time. Thank you, Tom. So up until like the third to the last slide, I was struck by how all these deaths were interchangeable, and how we were just counting deaths, but we didn't seem to be breaking them down by gender or age or anything, which was definitely not the story that we, like very quickly into COVID, we were telling a story about difference. So I was just wondering if you could talk about that a little bit and what role that plays in how you're thinking about the story.
Yeah.
Yeah.
No, that's a great question. So this has to do with kind of how people thought of population categories in the 1890s. So often these deaths are divided by gender, so you can compare men and women. Often they are divided by age and different age groups, and almost always under less than 1 year, under 5 years, and then various configurations of 5 to 15, kind of prime age and then elderly. The challenge with those is they don't always differentiate them both by cause of death and by those categories. So you can look at number of deaths in a month by gender, but not necessarily influenza and gender. They do bring that up sometimes. Mostly the gender is pretty similar. The number of men and the number of women. Her comment, first women are attacked, then men, and lastly children. That's the only place I've seen that. And you'd have to go back and probably look day by day, and the day by day isn't broken out by gender. They were very attentive to age. And one of the things that came up is that in the first wave, in the 1890s, very few children were affected. And so there was a sense this was a disease that mostly related to adults and even the elderly. In the second stage in New York, more children were affected. So that kind of threw that out. Like, we can't really say one way or the other. The two harder questions are, three. What New York counted was immigrants. They were really interested in the US Census, and we have the 1890s a volume from the 1890 census in the library, so I brought that down. Very concerned about relative health of different populations by immigration status, and not only the individuals, but where their parents were from. And so a lot of these tables are broken out by the nativity of the mother, the nativity of the father, were they native born, were they immigrants, and so on, but generally not also by cause of death. Maybe by some of the more common ones like pneumonia or tuberculosis, but often not influenza. So it's harder to kind of sort those through. The New York Health Department had a taxonomy of each of the 22 wards in the city based on kind of social class, density of population, immigration status, and employment. And so that would be a place to go and say, if you compare the deaths by month in these different wards, did in fact affect the poor more than the rich, and so on and so forth. But it's not broken out by cause of death. So again, you'd have to kind of look at the numbers and then see how confident you were. The other big category in this, of course, is race. And in New York, what was called the colored population was very, very small. And so they do break out those numbers in New York, but it's 40,000 deaths and less than 1,000 among the non-white population. But one of the things I've been looking at are other states, and so I'm working on a project now looking at Alabama, which had, I think, 40% African American, and there you do see those differentiations, and you can look more carefully at how the disease affected populations by race. And the U.S. Census, which happened in 1890, does provide documentation by racial categories. And so you've got some evidence there of where the population is. It's just in the Northeast cities like New York, it's still very, very small at this point in time. But your question is exactly right. How does it affect these different populations? And are there populations because of what they do, their occupation, or probably more importantly, where they live, that are more vulnerable to this disease than others?
Yeah, it was vulnerability.
Yeah.
Yeah, I just was wondering if that's part of the story.
Yeah, and implicit in this language, I think it's in this one, those who are much in the air and exposed to outside influences are more liable to attacks than others. Basically, this is part of her saying men are more vulnerable because they are working in the outside jobs, and therefore they're more exposed. It's kind of implicit in that comment. But mostly what happened is the first reports about lots of cases are in occupations that are also very visible. So policemen, railway clerks, teachers, pupils, where it's like you notice if there are a lot of people missing. It's never farmers, right? No one counts how many farmers are sick. They just get up and go to work, or factory workers or other kinds of things. And so I think those reports, they're both misleading in terms of documentation, but they create a misleading impression at the time that somehow police officers are getting more sick than anyone. Well, it's just because, every morning you have a roll call of the number of police officers, and people notice if people are missing.
Thank you.
Just come up. I don't know how to,
We have a question from Zoom. So, yes, so I'll come back to you though, Matt. So Fernanda has her hand raised. So I'm going to ask Fernanda to unmute and go for it when she's ready.
Yay. Thank you so much for this. Such a cool presentation. So Tom, I was thinking first about the science in action, and I was thinking, wow, If you have taken a look on another book that is very classical for this group, which is Sorting Things Out. I am suggesting this one because I was thinking about the question that Chris asked. How can we tell stories through numbers and through classifications and through variables? So it would be very cool to see this understanding. And I think this book will support, and I think you'll have fun looking at it.
Okay.
And then I was thinking about another thing that I also feel very interested in, which is the relation of people from medicine, medicine practitioners, physicians, the relation of these people with misinformation and disinformation. And I say that because I was doing some research on the origins of rumor between COVID-19 and 5G antennas. And I don't know if you have heard of this rumor, but it generated lots of antennas being burned out in Europe, dozens of them. And then I was looking at what is the origin of that. And one of the origins that we have found, I did this research with a colleague, Diego Vicentin. One of the origins was like a physician who was asked in Antwerpia if the amount of antennas in Wuhan, China, 5G antennas, had any relationship with the spread of COVID. And then the doctor said, I can't confirm that, but, and then that simple positionality, take that interview, it was in German, then it spread in English, and then we started to have that rumor all around. So I was thinking if, is there any kind of interest of you, because you mentioned disinformation or misinformation in the beginning. But I was thinking if you have any interest in going this direction, studying that. And if so, there is also a recent book from Amit Prasad that talks about, although we think that the misinformation is diminishing, reducing the power of science, actually, it seems that we always need the authority of a doctor to bring that misinformation or disinformation, even if the doctor doesn't exist. So this book is Science Studies Meet Colonialism.
Okay.
So all to ask about, like, is there any interest in going ahead in this idea of misinformation and these authorities, or what is your point about studying misinformation in regard to this topic? Thank you.
Yeah, no, that's really helpful, and I appreciate the two suggestions of other things to look at. Yeah, absolutely. You know, and as I mentioned, the two recent presentations I did, one on quinine as a treatment, and then the other on whether influenza could be spread through banknotes, you know, very much reacted to the experience with COVID. You know, and the ways that certain claims, and your example with the 5G antennas is a really good one, where a kind of, you know, partial or incomplete or incoherent, you know, endorsement by an authority, whether it's a medical authority or scientific authority or a government agency, then becomes reproduced in these cycles and exaggerated and amplified and so on. And I think one of the reasons I was interested in Louise Fisk Bryson, you know, is to kind of ask the question, where does her information come from? You know, how does she know what she thinks she knows about influenza? And in some cases, it's pretty clear because she's talking about case studies of patients. Now, again, whether they're her patients or a colleague, you know, she's got this like really detailed kind of temperature, number of days, symptoms, outcome. But then when she talks about earthquakes and electricity, she's clearly just making it up. You know, she's drawing kind of causation from other things that are in public discourse. and saying, well, these things are happening, and now we've got this epidemic. Are they connected somehow? You know, and she doesn't make a firm claim about it, but you can see how that would then easily get reproduced. And often when you look at newspapers across the United States, what they'll say is a New York doctor said this. They don't even necessarily have to have the doctor's name, but there's something about, you know, the New York, the location, not just geographically, but kind of conceptually, that gives endorsement. Now, sometimes you look at those and you realize it's actually an advertisement. There's a whiskey that explains the medicinal value of whiskey for treating influenza, but their opening line is, you know, a prominent New York doctor said, you know, this is the right treatment for the disease. You know, I hesitate a little bit about misinformation as a category. And this may come from dealing with too many computer scientists and their kind of binary view of the world. But I think information and misinformation are often on a gradient. You know, and there are things that are clearly, you know, misleading and false and even destructive or damaging. But there are also a lot of things in between. You know, is there any relationship between the spread of the disease and the atmosphere? Well, no, not in the way they thought about it in the 19th century. But yes, in terms of where people are and what is in their living conditions or their working conditions, or are they on the bus, or, you know, in these other conditions, you know, in these other settings and situations. And so I'm cautious about trying to draw a clear line and say this is information and accurate and this is misinformation and inaccurate. Even though, you know, some people spend an awful lot of time trying to define those boundaries very carefully. So yes, so Fernanda, thank you very much for those suggestions, and I continue to be interested in this, and I think this is something I've come back to differently after COVID than the way I was thinking about this before.
This feels strange.
I am backing up. The closer you come, if you don't start talking soon, I'm going to be all the way back there.
So waving science in action in front of this group is a little bit like waving catnip, and so I want to pick up on that a little bit and connect it to Fernanda's question and comment, and to your point about misinformation, because, you know, when you started talking about Latour, and then you made the case that these epidemiologists claim that they were 100% accurate, it gets right back into like information and misinformation. And I'm just curious about the role of the construction of statistics and epidemiology at this particular moment, whereas I've got to imagine that in kind of more theoretical domains, that the whole point of statistics is that there's no such thing as certainty, and it's all about trying to limit the error in what you're analyzing versus the context of public health statements, where it sounds like if you don't say it's 100% accurate, if you add the word "but," you know, they're going to burn down the 5G towers. And so I'm curious about that, because that really, like, statisticians saying we're 100% certain seems like an anomaly. And then I guess kind of connected to that, I'm curious about what particular new techniques are being developed in this space as a consequence of trying to respond to these epidemics. And so the thing that comes to mind is like infographics. So like when you recreated the charts of deaths, it's kind of like a one-to-one correlation with how we think about infographics now. I'm curious how those visual representations were being designed from this kind of statistical analysis for a kind of more public audience.
Yeah. Let me work backwards, because the last question, the New York Health Department reports have almost no graphics in them, which is unusual for this time. The US Census vital statistics for 1890 is full of diagrams and charts and maps and other kinds of things. And other statistical reports I've looked at also have them. So I don't know what it is about New York. It's all text and it's all numbers. They don't even have a map of the city in there. Now, having said that, in this era, often some books would have fold-out pages, and those generally don't get scanned by Google Books. So that's my only caveat. You know, it's like, it's possible that parts of these books I can't see because the versions I'm looking at from HathiTrust or Google Books or wherever don't always have those scanned, but I haven't seen anything. But the census has lots. You know, they do it excuse me, by maps, comparing different regions. They do it over time. They do all kinds of different things. So they're clearly trying to figure this out. I think in terms of the 100% certainty, and this is where many of you in this room have more expertise than I do in terms of a kind of history of science. I mean, this strikes me as a period when there was a lot of arrogance. There was a real commitment to be absolutely absolutely certain, to get the exact right answer. And you can see this with, when they're trying to track down the microbe that causes influenza. They've got the microbe for cholera, they've got the microbe for tuberculosis. Like, they want the exact thing. And they're willing to argue and debate and contest and so on and so forth. And so I think the statisticians are trying to do the same thing. They want an exact answer. What I see in reports from other states is they know they're incomplete. So the Alabama health reports say, we've only got reports from half the counties. We'd like to do better. We send out reminders, we send out encouragement, we're just not getting them. And so when you look at those reports, and it took me a while to figure this out, they're really incomplete and almost on some level useless, except you can use what's there, but you can't make generalizations about them. And so the New York one, the Connecticut one also, but especially in New York, they just think they're better than anyone because they are, with deaths, 100% accurate. And so it's almost a totalizing vision. If a death happens in New York, we've counted it. It's in our tables someplace in the right. There's a category of other causes or unattributed deaths or whatever. And so I think, that's what intrigues me. How do they go from something that is unpredictable and messy and extensive and try, in some sense, control it and say, this is exactly what happened. We've captured it in our numbers and in our tables. I think what's missing in all of this, from my reading of Science in Action, is I don't have any of the internal deliberations from these statisticians. Nobody says, in what I've seen, we don't have these numbers. What are we going to do? Well, let's fill them in or make them up or something else. But they are out in public, and the newspapers do report, and they do, as in those few examples I gave you, they do talk about how they're counting the deaths. And in some cases, the newspapers are even, as of noon today, this is the number of deaths, or as of 5 o'clock yesterday. They're not even waiting for the complete numbers to come in. They've got this sense of real time. We want to know right now. It's an evening paper. Let's get the morning numbers in. And so that is one place where you can kind of see into the process, but you don't get the deliberations from within that group. I'd love to have them, but I don't think I'm going to find them. I don't think anybody kept diaries or wrote a memoir or anything else that would provide that the insights into that process. Does that answer your? Okay.
I'll follow up.
All right.
I'm not supposed to talk from there.
It's just because I can't hear you.
You're a runner, you can run right back up there.
Thank you for the presentation. My name is Kulyash and I'm a graduate student in Department of STS. I have two questions. Can you comment on the eugenics context, because it's sort of like the heyday of those ideas, and what would Dr. Frisk-Bryson say about the kind of how she would picture that? And also, was the term Russian coined back then or later on as historians started to study it, and how that was constructed, maybe in comparison with the Chinese virus?
Okay, those are excellent questions. So, yes, this is the early stage in eugenics, and there are connections between, especially public health officials, and eugenics. And to some extent to statisticians, because they were trying to make predictions and account and so on and so forth. I have not seen any discussion of eugenics in the context of discussions of the influenza epidemic. Nobody says that this is affecting certain populations more than others, other than what we talked about earlier in terms of gender or age, occupation. But you don't see directly this discussion that in the US context, native-born are less vulnerable to influenza than immigrant populations. But it may be there, if I keep looking, it may come up. I mean, the census documents, all of these public health records, they do pay attention to, as I said before, immigration status, social class. Marriage doesn't come up so much, in terms of that. But this is something I need to be more attentive to. I suspect if I read more of Bryson's articles, there would probably be eugenics in there pretty prominently, because she's very concerned about reproduction and upbringing and comportment and other kinds of issues. But it doesn't come up in this particular context. But this is certainly something to be aware of. The Russian flu, that's easy. That's the name they give it right away in December of 1889. It's first reported in St. Petersburg, and initially they talk about an respiratory disease, influenza, but then as soon as it looks like it's traveling and coming to Western Europe, they start referring to it as the Russian influenza or the Russian flu. And they use that term all the way through the spring of 1890. As it spreads around the world and talk about it in different places. As you heard, my background in is Russian history. So I was really interested in that. And there's actually very, very few cases where they attribute any kind of cultural significance to it being the Russian flu. One of the first articles in the London Times says it's because the Russians are unsanitary, and therefore they got this disease first. But that's not really a tenable argument once it comes to Berlin and Paris and London. And in fact, they probably have it worse in those Western cities. So that argument kind of goes away. The only three places it stays, there's a lot of talk in the American newspapers about how because the Russian language is so hard to pronounce, has lots of sibilants, it somehow makes it sound like people are sneezing or coughing. There's some really bad poetry about the disease, some of which references Russians. I will spare you. I subjected a panel to several examples of this a few years ago and won't do it again. The only other place it comes up, and I wrote about this in the Washington Post article that was cited earlier, is there's speculation that maybe the disease began in Bukhara in Central Asia, what is now Uzbekistan. And that it then came from Bukhara to Russia, and then from Russia to Western Europe and the rest of the world. That speculation goes back to a single doctor, an Austrian doctor who was on assignment with the Russian army in Bukhara in the summer of 1889, and there was an outbreak of disease, which they thought at the time was malaria, and may have been something else. And it was treated, and then when he heard about this disease outbreak in St. Petersburg in November of 1889, he said, hey, that's the same disease. It must have started in Bukhara, and he wrote an article about it in a Vienna Austrian medical journal. And then much, much later, a British scholar picked that up. And now it's kind of become common knowledge. How do I know that? It's in the Wikipedia entry for the Russian influenza, and it was the first line of a New York Times article about the 1889 Russian flu. I should bring it up. It's got this. It's very vivid. A disease swept out of Bukhara and crossed the entire globe, or something like that. And so it's an interesting example of how one explanation of how a disease begins can gain traction and kind of stick around for a long time, even though most other accounts say there were lots of places where this could have begun. It could have begun there. Could have, lots of places where there were kind of outbreaks of disease. And if you look at the timing, it's in Bukhara in August of 1889, and then it disappears, and then it shows up again in St. Petersburg in October, and then from there it goes quickly within weeks around the rest of the world. So, what happened? I think it's more likely that this was just another outbreak of disease, but it was attributed kind of as a causal explanation in a couple of cases that then got picked up and reproduced. And what brought this up, the reason I wrote that article, was this continuing debate about the origins of COVID in Wuhan, and was this animal to human transmission, or was this a leak out of the lab? And there's evidence for both, there's arguments for both. Both have become very, very politicized to the point where you can't really talk about them without engaging in some way with the political views one side or the other. Although there are some people who have tried. There's been some very good reporting that says, if we set aside the politics, here's the evidence. And the evidence ultimately, the evidence ultimately is inconclusive, in part because there's no access to the records from the Chinese government that actually might, show this transmission more reliably. So, did it start in Russia? Well, the Russians say, no, of course it didn't start here. It started somewhere to the east, probably in China. Others say in Central Asia. So there's always this argument about trying to kind of push it back someplace else.
So we have some comments, but before you go up, we have some comments from Ashley Shu online, who is doing a lovely job. She says that Matt's question is inspired by Taming of Chance now, towards the second half of his question. And then she mentioned that we're hitting everyone's favorite topics today as we started talking about eugenics. And then she finally wanted to mention there's some interesting stuff around eugenics and the tracking of who had different viruses on the punch cards used by Nazis as part of public health and then killing disabled people. It's in that big book, not War on the Weak, but the other one by the same guy, IBM and the Holocaust.
Ah, okay.
Yes. So thank you, Ashley.
Thank you.
And now, Saul, good call.
If you can do eugenics and Nazis in the same talk.
Thanks, Tom. That was a great talk. I was really struck by something you said, which that influenza was not being tracked as an important disease until this outbreak. Did I catch that correctly?
Mostly, yes.
Okay. So my question sort of circulates around that, because it suggests that what we're seeing here is basically the construction of influenza as an epidemic. And so influenza exists before this, but somehow it exists in a way that's not quite as disastrous, I guess.
Yeah.
So by this point, germ theory is well established, but we don't yet know anything about viruses.
Yes.
And so I wanted to kind of just ask you a question about the relationship between epidemiology and causation in the construction of disease. And in the present, we use epidemiology as a way to kind of make sense of the kind of contours of a disease, but we don't use it any longer to understand the disease in its sort of existence. Right now we go to DNA and genomic sequencing and all of that. But at this time, I understand you saying that really the disease itself is being constructed through the statistics. So I just wanted to know what your sense is about the relationship between, so we're pulling together things like pneumonia and bronchitis, right, which are observable facts, into something called influenza, which is not observable but is kind of intuited through statistical analysis. With the idea that we do have these things called germs that we can't quite understand, but we know they're there and they sort of underlie, and there's a kind of causal relationship. So I think that for me is where the interesting story here is at this moment. And I was just wondering what your thoughts are on how influenza is being constructed as a disease through epidemiology at this moment. Yeah.
Can you put the slide back up? I didn't get to this, believe it or not. So this is the the U.S. Census, which is what that volume is. The 1890 Census, Part 3, Statistics of Deaths, Table 18. This is the only place in the many thousands of pages that actually lists influenza as a cause of death. And it's not listed under influenza with an I, it's listed under La Grippe with an L. So it took me many tries to find it, and you can see what else is listed as an L. So this was the only place they counted it, right? There are many, many other tables by cause of disease, but they're in larger categories. And so influenza is somewhere there under sometimes respiratory diseases, sometimes miasmatic diseases. It shows up in lots of different places. And so I think it takes this epidemic to force them to differentiate and say, okay, this is something we need to count separately. So when I said mostly, they were counting it, but only in kind of very both limited, but also in really detailed ways, not in their general calculations. And so it takes this disease to go in and look. There are some states, and Alabama may be one of them, where they actually count at 2 different places, influenza and under I, and grip under G, or law grip under L. And so there's a lot of kind of pulling these things together. The other thing is these records, I think, are very incomplete. So when they did the census, they had what was called the census year. At this time, they don't anymore. That began in June of 1889 and ended in May of 1890. That's perfect because the epidemic is right in the middle. So it's actually easier to count it in the census year than in the calendar year. But the census reported only 6 deaths in New York City from la grippe in that year. The health department reported 317 in the same time period. So what happened? Well, if you combine pneumonia deaths and influenza deaths, suddenly you're back to a very similar number. And so I think what was happening is somehow when the census was collecting them, they weren't differentiating out influenza as much as the health department was. And so this is always the question. And I think it relates to what you're saying in terms of both the causation and the construction of the disease. If you're and I should have said this more directly in the earlier section, if you go into the epidemic believing one thing, that influenza is not deadly, at what point do you change your mind? And you start to say, no, it is, and if it is, we have to count it in some ways. And so I think they go in thinking this is not a deadly disease, we don't have to really think about it, worry about it, or count it, and then somehow that changes. And that's when they start reporting. And in some ways, the newspapers are better evidence for that, because, and the newspapers are saying, yeah, we're counting lots of deaths. Maybe there's maybe there's causation with the epidemic. And I think, I don't know, I'm going to have to think about your other part of your question, because they were all observing this, right? These were observed facts to them, how they interpreted, how they explained it, and I think also in the case of Bryson, how they predicted what would happen, I think is well, it's both interesting in its historical context, but particularly interesting for us given what we went through with COVID, right? Because one of the things you see in the newspapers is the public health officials, the statisticians keep saying, it's almost over. It's going to start to go down. Well, if you say that enough times, eventually you're right. They do go down. But they said it an awful lot of times, even as the cases and the death rates kept going up. And they never go back and say, yeah, we made a mistake. We underestimated. I mean, it's implicit a little bit in the public health reports, but not as much as it should be. And so for me, again, thinking back to particularly the spring of 2020, and then again, fall of 2020, early 2021, when the COVID deaths were absolutely at their highest, how did people make sense of these numbers? Not only the public health officials and the statisticians, but us, everybody. Did it matter to people that they, anytime they looked at a news source, they were confronted with these numbers, and they could look at those numbers on any scale they wanted to. So you could look globally, you could look nationally, you could look at Virginia, you could look at Montgomery County. In some cases, you could look at Virginia Tech. And how did knowing those numbers not only change your perception of the disease, but change your behavior, change the way you were interacting? And I think that was going on in early 1890. I just don't have the evidence for it. And I'm trying to figure out what would give me a reliable measure. And full confession, part of the reason I invited myself to come give this talk was because I had applied to the National Science Foundation for a grant through the STS program, and they turned me down. And Dr. Allen, I don't know if she's on the call or not, had read the first draft and made some excellent suggestions, not all of which I followed, and several of the suggestions she made were then appeared in the reviewers' comments. So I submitted it again, and it got turned down again. And so I submitted it a third time. I think I'm in that stage. But one of the questions from the reviewers was exactly this. How do you demonstrate that quantification changes behavior and changes attitudes? And so I keep coming back to that question. I mean, there are lots of numbers. There's lots of evidence that people could count this disease as it was happening. How did it change their behavior? And I'm just trying to figure that part out. And I expect to be turned down again in a few weeks, and then I'll reapply. I don't know what our timing is. I'm happy to keep answering questions.
very quickly.
Well, the last part of your answer just now made me think about the ways in which we've tracked behavior change during COVID. Some ways in the negative, right? There was an observable decrease in general mortality from infectious disease because of the isolation and masking protocols that we followed. So you could map the evidence of behavior change not from COVID itself, but from the other mortality rates. Still deriving it from data in some sense, but in a really weird roundabout way that I think speaks to the Janus-faced element of data. So I'm curious, because I was trying to figure out how to phrase it for the entire time. My question was going to be very similar along like, what behavior changes did we see historically documented by newspaper evidence or, physician recommendations to, and yeah, I don't know. I was just curious what you saw or if you could map it through the negative like that.
I mean, it's more feasible for the 1918 flu because there were more public health measures, and so things, there was no discussion in 1889 or 1890 about masking, about restricting hours for businesses, about closing schools. Some businesses, factories did close, but they did it because there weren't enough people there to make it work. But there was no kind of preventative measure, or there's no discussion of social distancing. A lot of that comes about even before the 1918 flu because of the anti-tuberculosis campaigns. And so the, cover your cough, avoid crowded spaces, stay home when you're sick, that comes out of anti-tuberculosis, which is just getting started at this time. But they were basically helpless with this. I mean, you saw that, just stay home, call a doctor, was all they, and the doctors couldn't really do very much. So it's harder to measure, those kinds of changes when you don't have a government saying, first do this, we're requiring you to do this, and then again in the case of, this is one of the things we looked at with 1918, when people disobey, they don't follow the rules. So the resistance to masking or the non-compliance, then you have evidence. People are supposed to behave this way. Some of them are, some of them aren't. What can we do with that? It's much harder to find that for 1890. All right, thank you. Thanks, everybody. Appreciate it.
I'm going to. Thank you guys for coming. I just want to give everyone a reminder that next week is the annual 4S conference in Hawaii, so we do not have seminar, and then we have 2 weeks for Thanksgiving. So actually our final seminar of the semester is going to be a roundtable on public interest technology on December 4th, which is a Monday, not a Friday, but you will be receiving another reminder from me. So yes, thank you all so much, and I hope you guys have a great rest of your weekend.
Thank you.